Hello, my name is Robert Heggie and I'm a research associate at the Health Economics and Health Technology Assessment Group at the University of Glasgow. So I hope you're enjoying the conference so far. The title of my talk is a sample size calculation from a net monetary benefit perspective, and it is a case study in the management of NSTEMI patients with previous bypass surgery. This work was developed alongside a few colleagues, Professor Olivia Wu, Dr. Kathleen Boyd, and Professor Colin Berry. So I'll start by just giving a quick overview of the talk. So I'll describe briefly what the feasibility study was. So unfortunately there wasn't a great acronym for the feasibility study, which is called the Cabbage ACS feasibility study. So I'll describe what was compared in this study and what were the results. I'll then give an overview of the cost effectiveness analysis that we did using the trial data. I'll explain what our results were and what this suggests about potential future research. I'll then explain how we tried to estimate the sample size required for a phase 3 trial of clinical and health economic outcomes. And then finally, I'll compare and contrast the net monetary benefit approach to sample size calculations with the more traditional approach to sample size calculations. So the study population here is non-ST segment elevation myocardial infarction patients. For these patients, there were 10 clinical trials that supported the use of invasive management using something such as a stent. However, approximately 10% of this patient population present with a history of previous bypass surgery. Unfortunately, these patients were omitted from the 10 clinical trials. So for these patients, the use of invasive management compared with non-invasive management such as medical therapy is unclear. So as this was a feasibility study, the primary study hypothesis was just basically that within this patient population, that randomization to non-invasive management, medical therapy, was feasible, and this was measured in terms of adherence to strategy at 30 days. So the main reason that they were interested in this, the whole motivation for the study, was really the hypothesis that non-invasive management was clinically non-inferior to invasive management. So in addition to feasibility, composite outcomes were measured, including efficacy and safety. And these included outcomes such as all-cause mortality, MI, bleeding, stroke, and a few others. So the study found that randomization to non-invasive management was feasible. In addition, they found that the efficacy outcome occurred in 13 patients in the invasive arm, compared with 13 patients in the non-invasive arm. And the safety outcome occurred in 8 patients in the invasive arm, compared with 9 patients in the non-invasive arm. So this suggests there's very little difference in terms of clinical outcomes. So data on other outcomes, including quality of life and cost data, were also recorded. Using this information, we undertook a cost effectiveness analysis. So for each management strategy, non-invasive and invasive, we calculated the mean total patient cost, and this was comprised of complication costs and procedure costs, and we estimated the mean total quality gain over 12 months. This was based on EQ5D and undertaken using the area under the curve method. We presented the results in terms of the incremental cost effectiveness ratio and the net monetary benefit. We also conducted a probabilistic sensitivity analysis and undertook a value of information analysis to estimate the value of future research. So our results found that non-invasive management was associated with a reduction in total mean cost of approximately £1,500. And this was alongside an increase in QALYs of around 0.038. So this equates to an incremental cost effectiveness ratio of about negative £39,500 and a net monetary benefit of about £2,262 per patient. Therefore, from a cost effectiveness perspective, non-invasive management dominates invasive management. It's cheaper and it's more effective. We undertook a value of information analysis, and this found that the expected value of perfect information was between £2 and £10, depending on what assumptions we made around uncertainty and parameter estimates. So we were asked to contribute to the design of a phase 3 clinical trial of clinical and cost effectiveness outcomes. But in order to determine how many patients were required for a phase 3 trial, we first had to decide what outcomes we were most interested in. If we were primarily interested in clinical outcomes such as safety or efficacy, then the research hypothesis may be that non-invasive management in terms of clinical outcomes is non-inferior to invasive management. However, if we're more interested in cost effectiveness outcomes, then the net monetary benefit approach to sample size calculation proposed by Henry Glick would be a good option. However, the pre-trial cost effectiveness work that we just outlined, this suggests that non-invasive management dominates invasive management and that there's very little value in future research. However, the feasibility trial, of course, wasn't powered for cost effectiveness outcomes, so there's a lot of uncertainty around these results. So using the data that we had on cost and qualities, we went ahead and we undertook a sample size calculation from a net monetary benefit perspective. So our base case, we found that the sample size required using this net monetary benefit approach was 4 patients. So obviously this was a surprising result. However, perhaps it shouldn't necessarily have been. This does really just reflect the fact that there was only a small difference in qualities between groups and a really large difference in cost, with non-invasive being significantly cheaper. So we also assessed how the sample size required changes when we make alternative assumptions around the quality gain between groups. So the shape of the sample size, the shape of the curve here we have in the diagram, it's best understood, I think, in terms with regards to the actual net monetary benefit formula. So the first part of the formula, we're changing effect, we're changing qualities multiplied by our willingness to pay for qualities. So this basically gives us a monetized estimate of the benefit of the new intervention, and we subtract from this the cost. And the purpose of the net monetary benefit calculation is to show, is to assess whether or not the net monetary benefit of your new intervention is significantly different from 0. So if you're going to have a large net monetary benefit, it makes sense that you would only require a small number of patients to demonstrate this was different from 0. And that is what's the case here. What's quite striking in this graph here is that you see for most differences in quality gain, the results are quite stable and a low sample size is required. But there is a point at which the sample size required explodes, and this is around about negative 0.78 qualities associated with non-invasive management. So rather than the base case of non-invasive management having slightly higher qualities, if it turns out it was worse and it was exactly 0.075, that's the point at which the net monetary benefit would actually equal 0. And because that's our effect measure, because that's near 0, what happens at that point is that your sample size required basically explodes. But this makes sense. This would be the same thing in terms of clinical outcomes. If outcomes are very similar, you're going to need a really large sample size to show a difference. We undertook the same procedure, just looking at differences in cost. So again, we've got our base case where we need just 4 patients. And again, here, the results are reasonably stable. They all suggest a low sample size required. There is, again, a point at which the sample size explodes if it turns out then, rather than being cost-saving non-invasive, if it was more expensive, in particular, if it was £760 more expensive, at that point, the net monetary benefit becomes 0 and you need a huge sample size again. But given that non-invasive was quite significantly less expensive, about £1,500, it seems quite unlikely that it would, in reality, actually be about £760 more expensive, but the uncertainty is, of course, there. So, as a sensitivity analysis, we also explored the traditional method for estimating sample size. So, based on the motivation for this study and the hypothesis around non-invasive being potentially non-inferior, we decided on a non-inferiority trial design. So to do a non-inferiority sample size calculation, you need 2 things. Basically, you need a difference in effect between treatments. So this could be based on something like a minimum clinically important difference. But for our outcomes, clinical outcomes, for efficacy and safety, these were composite outcomes, and it wasn't really clear exactly what a minimum difference, a minimum clinically important difference would be here. Another approach is just to assume there's no difference between treatments. It really, that's what the feasibility showed, was there is basically no difference. So that was the assumption in our base case here. You also have to specify a non-inferiority margin. So this is a margin within which you'd be willing to say that the new intervention is not unacceptably worse than the standard So in this case, it would be that non-invasive management isn't unacceptably worse than invasive management. So when we did this, what we found is that in our base case, when we assume a non-inferiority margin of 5%, you see you need about 3,000 patients for an interesting efficacy outcome, and about 2,500 patients if we're interested in the safety outcome. And this changes for other margins, non-inferiority margins. But again, the results can range from requiring about 2,500 patients to about 8,500 patients. So either way, this would be a significant trial in terms of sample size. So really, what our results seem to show is that there's a large difference in the sample size required from the perspective of a cost-effectiveness analysis than from a traditional non-inferiority trial design. Hence, our results seem to imply contradictory recommendations depending on which perspective you take and which outcomes you're interested in. The results in terms of cost-effectiveness, this is really driven by the small difference in quality of life between treatments, but a large difference in cost. So based on the current evidence that we have, it seems that cost-effectiveness analysis suggests non-invasive dominates, and the VOI suggests that there isn't much value in future research. However, the question is, do we need more evidence on clinical outcomes? Are we satisfied with this net monetary benefit approach that's just based on cost and qualities? Do we think clinicians would be willing to implement based on these findings, or is there too much uncertainty around the clinical outcomes? And should we perhaps consider an adaptive trial design where we assess sample size at predetermined time points based on collection of the data, assessment of the data, that's clinical and cost effectiveness data, as the trial proceeds, and then use this to determine the sample size required. So thanks for listening to my talk. I hope you found it interesting, and please do get in touch if you have any thoughts, any questions, and enjoy the rest of the conference. Thanks.